Hi, everybody, and welcome to the Research Roundtable. This is an event we've all been looking forward to. Two brilliant minds getting together to talk about breakthroughs, emerging trends, the latest stuff. Before we went live, Dr. Chen showed me a 3D model. Everybody buckle up. This is going to be amazing. Let me do a proper introduction. Of course, we know that tonight's roundtable is moderated by our Chief Medical Officer, Karen Herbst. Dr. Herbst, so great to see you as always. And let me introduce our esteemed guest, Dr. Chen. It is an honor to introduce a trailblazer in the world of lymphatic supermicrosurgery and medical innovation, Dr. Wei Chen of the Cleveland Clinic. Widely recognized for pioneering research into the intricate relationship between the brain and the lymphatic system, a frontier of medicine that is transforming how we understand neurological health and inflammation and disease. His work has illuminated pathways that once were thought to be non-existent, revealing how the brain may clear waste, manage immune responses, and unlock new treatments potentially for conditions ranging from Alzheimer's disease to traumatic brain injury. I could go on and on. We know that you are logging on right now. We're seeing you say hello from Arizona and Canada, and let us know that you're here. We're so glad you decided to join us for the live. And there will be time for questions, we promise. We'll get to them eventually. Put them in the Q&A. Dr. Herbst will navigate and weave them in as we commence an amazing conversation brought to you by Lympha Press. We are honored to set the scene for you. And now I will disappear. Have a great conversation.
Thank you so much, Brenda.
Thank you.
Wei Chen, again, just so nice to have you here. I obviously have followed you over many years and referred many patients to you, and your work is always exciting. And now I don't even know where to start because we just talked about some really cool stuff. But I do have some questions that I think will start to bring us to that 3D model and also the brain. And at first, just something kind of personal. Can you tell us something about yourself that most people don't know?
I play a lot of video games, and actually, I'm starting to prescribe my kids, my two boys, 10 and 8, to play video games. And interestingly, both of them complain when playing video games is mandatory. They complain. So there have been extensive studies demonstrating the benefits of playing video games. The key is you can't play too much or too little. It needs to be just right. And if you're interested, you definitely can look up those studies.
I have played video games in my life, and I would say I might play a little bit too much when I get involved, but I have liked them very much. Okay, so the next thing, as Brenda introduced you, you really are a super microsurgeon. And can you just kind of tell us what you do? Like, what is your life like in and out of the OR?
Uh, so uh, for people who may not know what supermicrosurgery is, basically supermicrosurgery is an extension of microsurgery, and microsurgery is basically utilized in all major reconstruction. Whenever there is a major defect in the body, for example, following the cancer resection, whether it is in the brain, whether it's in the head and neck region, trunk, torso, chest, abdomen, arm, legs, whether or traumatic injury or war injury, anytime there is a major defect in the body that requires reconstruction, microsurgery is involved. And that has to do with the fact that when we move tissue from a part of the body to another part of the body, we can't simply take that piece of tissue. We need to take it with its own blood supply. That means arteries and veins. And sometimes when we try to rebuild, say, for example, when we try to hand transplant, for example, that is an example of microsurgery. You harvest a hand from a willing donor who is now deceased. Um, you need to reestablish not only the arteries and veins, you also need to reestablish the motor nerves and the sensory nerves so that the hand can become functional. So that's microsurgery. Supermicrosurgery is just an extension of it. It just means that we are now breaking the boundary of microsurgery, which traditionally was at 1 millimeter, or more precisely at 0.8 millimeter. And that's where supermicrosurgery starts. And once we get into the world of supermicrosurgery, we then discover possibilities, namely turning conditions that were once considered untreatable to treatable conditions. And the current lower limit of supermicrosurgery is 0.1 millimeter. And we are completely looking forward to breaking that lower limit with modern technology such as the robot, the next generation robot. And who knows what we will be able to treat tomorrow as we get even smaller.
So you mentioned the brain, head, neck, and you and I had a conversation at the Center for Vein Restoration meeting, and you were telling me about these amazing studies on Alzheimer's disease or dementia that were coming out of China. Can you talk a little bit more about supermicrosurgery or just microsurgery in general and dementia?
So this actually, interestingly, there were two parallel tracks of studies. So the studies performed by neuroscientists who had discovered brain having lymphatics, and the brain actually has two components to its lymphatic system. There's the meningeal lymphatics and there's the lymphatics. And neuroscientists from around the world have been working on this topic since early 2010s. More specifically, 2012, that was when the lymphatics was discovered. 2015, meningeal lymphatics were discovered. And since then, the cause and effect relationship between the brain's lymphatics and various brain disorders, including Alzheimer's and Parkinson's disease, have been established. So that's what the neuroscientists have done. What we clinical lymphologists have done is we initially in our patient, we always heard many patients reporting that lymphedema patient. Now we're not talking about Alzheimer's patient. We're talking about lymphedema patient, especially in primary lymphedema patient, many of whom reported cognitive deficits. And since we see a lot of them, we started to pick up that there is a pattern. They seem to associate with primary lymphedema. And once we started looking into it, we found out that it's about 30% of the patients with primary lymphedema will report notable, frequently lifestyle limiting cognitive impairment. And many of them will report brain fog, short-term memory issues, attention deficit, and actually many patients were diagnosed with attention deficit disorders. And your area of expertise, lymphedema, it's also strongly associated with lymphedema. And the next thing that we found out is once we have performed surgery on these patients, so many of whom, and to a very high percentage, reported reversal, full reversal of these cognitive impairment. And these included those who initially reported cognition impairment, as well as some who never realized they actually had cognitive impairment. And then following the surgery, they realized, whoa, I feel so much sharper now. And I didn't realize I had such significant brain fog prior to surgery. So after seeing so many patients, we can easily dismiss the first 10 or 20 being psychosomatic. But after seeing so many of them coming back and telling us how lymphedema treatment, and in fact, not only surgery, lymphedema treatment had an effect on their cognition, we came to the hypothesis, and we tried to publish this back in 2016, that the very same surgery that we've been performing to treat extremity, truncal, and central lymphedema may be able to treat Alzheimer's, which at the time was already found by neuroscientists as brain lymphedema.
So
And
I have a quick
and
question for you on that. I use amphetamines to improve lymphatic pumping, and it also does, many other things like decrease fat. But when people take amphetamines, they report improved cognition, even if they do not have a diagnosis of ADHD or ADD, or don't have any behavior to suggest that they have ADD or ADHD. Do you think that it could be because lymphatic pumping is improved all over the body, including in the brain, with that medication?
I think all we can do is hypothesizing right now. There's so much unknown, but what we can say is the more we study the lymphatics, the more we see that the lymphatics are incredibly interconnected. And it's rare, I wouldn't say never, but it is rare to see lymphatics behaving in isolation. We rarely would see lymphatics improving or deteriorating in isolation. So when your patient who has, say, left leg swelling tells you that, well, this being a primary lymphedema patient, and the patient is only symptomatic for swelling in the left leg, and now the patient's swelling has improved, chances are, if you check the patient's body, you will see that the lymphatic function has improved everywhere. So if there is a mechanism that would reliably improve the peripheral lymphatic function, I think it's certainly possible, based on what we know today, that there may be a therapeutic, beneficial, favorable effect on the brain's lymphatics.
That's fascinating. What are your thoughts on GLP-1 agonists that decrease inflammation?
So yeah, that I know that is the hot topic nowadays, and thanks to our colleague Dr. Joe Dayan's very important study, and I think, but at the same time, um, I think what GLP-1 agonists have proven to be effective for is weight loss. And the effect we have seen in those two early studies demonstrating favorable effects on lymphedema are already sufficiently explained by the weight loss. So we definitely are not excluding the possibility, and we are looking into, and I think this goes for Dr. Dayan's team also, are looking into whether this class of medication has any intrinsic effect, beneficial effect on the lymphatics. The observed benefits, as I said, could be explained just by weight loss already. Of course, we hope that there are intrinsic benefits, but that remains to be proven.
Okay, that's very interesting. So back to the brain, do you think that, so what would you do, or what can you do to improve dementia, brain fog, cognitive decline? How would you approach a patient? If
So,
you could, if they
so
said, here's the
it's
operating room, do what you want.
yeah. So as I said, 2016 we came up with that hypothesis, and we tried to publish that idea, and you can imagine how well it was received.
Yes.
And our paper was bounced back everywhere, and we couldn't get it out. So I talked about it at various meetings, and we were made fun of left and right. So that was the end of it, but we continue working on this topic, looking into this correlation between the peripheral lymphatics and the brain lymphatics, and looking into how, by modulating peripheral lymphatics, what kind of effect we can get on the brain lymphatics. Until in 2022, the first case was performed in China. That to us was a surprise. Um, of course, we then reached out to the Chinese surgeon, and well, as they said, people who are working on the same topic with think alike. Their surgical design is uh, identical to our first generation surgical design, which is performing LVA in the neck region. And this is taking advantage of our discover phenomenon of, as I said, lymphatics don't improve in isolation. So if you improve regional lymphatics, the entire body seems to improve. So this is the systemic effect of lymphatic intervention, but there's also a regional catchment effect. This means that wherever you perform the surgery, that area tend to see the most improvement. So swelling and the like, you perform your surgery in the leg. Problem is in the brain. At this point, we're not quite ready to get into the brain yet. However, can we perform the surgery closer to the brain, say in the neck? And that was our original thought. And if you look at the brain lymphatics and how the brain lymphatics interact with the extracranial lymphatics. So you have intracranial and extracranial lymphatics. Where do they communicate? Well, there are two major pathways. Well, at least there are two major pathways that have been discovered. There's the anterior pathways that go through our eyes, and the lymphatic plexus travel along the optic nerve and then come out through the orbital plexus, and then they drain to along the cheek to preauricular lymphatics, and the other pathway drain across the cheek obliquely down to the submandibular nodes, and then from here they get into the neck. That's the anterior pathway. The posterior pathway drain through the jugular foramen. Hang on a sec. So here is a skull, the jugular foramen right here. And so from the jugular foramen, the lymphatics come out, and the first zone that it runs into is the level 5 lymphatics. So roughly in this region. So our original surgical design is to perform lymphaticovenular anastomosis or the lymphatic bypass in level 5. And since then, we have changed our surgical design to lymph node to vein anastomosis. And that is due to a concern, a theoretical concern of backflow or blood refluxing into the lymphatics. And there is a potential for serious complication. And therefore, we converted our surgical design from LVA connecting lymph channel to vein to lymph node to vein anastomosis, LMVA. This way, if there's a high venous pressure and you get a backflow into the lymphatic system, then the blood would reflux into the lymph node. The lymph node would stop the backflow. But there are many benefits of converting LVA to LMVA, including what we were just talking about before, that LMVA as a procedure seemed to be even more powerful, at least based on our now this is our 3-year study into looking into LMVA in comparison to LVA. As I told you, I call it LVA on steroid or the super LVA. So that's what our second generation surgery is based on. We're now on third gen surgery for the brain lymphatics, which hopefully we will be revealing soon.
So is it that there's something about the neck drainage of the brain that's inadequate? Is the design of the lymph nodes in the brain inadequate, or is it, do things change in the neck over time, like with aging, that decrease drainage? Or what are your thoughts there? Why don't we all drain just great?
So based on international data, the Chinese data and the Korean data, there's a Korean study performing ultrasound in patients in the neck of patients with Alzheimer's, and they found significant asymmetry in level 5 lymph nodes, and only in level 5 and only in patients with Alzheimer's. And according to Chinese data, patients with Alzheimer's have abnormal neck lymph nodes. Now, these are findings that we, as of today, cannot replicate here in the US because of various regulatory limitations, and we're much more tightly regulated than our Asian counterparts. So what they could study in human, we are studying in animal. And we are already receiving many inquiries from patients hoping that we can help either themselves with Parkinson's or their spouses with Alzheimer's. And we are about 1 to 2 years away from an IRB approved human trial. So as of today, we we have our hands tied, but we are not sitting idle. We are investigating these questions indirectly in lymphedema patients. And as I said, various brain disorders based on what we understand today are brain lymphedema. And if they are brain lymphedema, they behave like lymphedema and they respond just like other lymphedema.
So I was reading one of your many publications, and in there, in this publication, you talk about primary lymphedema. This was published in 2024 in Plastic and Reconstructive Surgery Global Open. And you say that primary lymphedema is a systemic disease. So would people with primary lymphedema also be at risk for slow brain flow, do you think?
I think we don't want to get ahead of ourselves, and that certainly is a possibility, but we really don't know. What we do know is that when we look at patients with primary lymphedema, and just put people at ease, I'm sure that there are people in the audience with primary lymphedema. They're freaking out now. Well, I wouldn't be. I wouldn't be. What I most frequently see is that, well, the most common presentation of primary lymphedema, as we all know, is swelling in the leg. And interestingly, 70% of the time, it's the left leg. Left leg is so frequently the initial presenting symptom. And then over time, many patients will develop a second site of swelling, and which is most commonly the contralateral leg. So initially left leg, then second leg. Well, the second site of symptom would be the right leg. Most commonly, the rest of their body are very mildly affected, and that's what we see. Usually one leg is the most affected, with the contralateral legs somewhat more affected, and with the remainder of the body very, very mildly affected. In fact, for many patients, their arms are so mildly affected, if the patient didn't receive an ICG lymphography, but instead they received the conventional technetium 99 lymphoscintigraphy, we already know those patients are going to get a normal result on lymphoscintigraphy. So I think people don't need to be overly alarmed. This is a very early stage. So that's the most common presentation. There certainly are patients with more compromised, more weakened lymphatics in the rest of the body, and that's why it is important in primary lymphedema to study all four extremities. So if we see very, very mildly affected upper extremities and patient doesn't have any intestinal or visceral symptoms, central lymphatic symptoms, then I don't think we need to perform invasive diagnostic test to look at the central lymphatics. We can assume that the rest of the body is also fairly mild. However, if the arms are not mild, then further investigations are worthwhile.
Okay, so it could depend on the person, but in general, people with primary lymphedema have their legs affected most of all, and their arms could be normal, which means their brain could also be fine.
So what I usually tell the patient is, just because so many our physiologic functions are not 100%. Whether we were born with not being 100% or we lost those functions as we age, aging definitely would create a loss of physiologic function, or we don't take good care of ourselves. For example, excessive drinking, not having good sleep hygiene, which I myself am guilty of. I don't sleep enough. So we would lose all these physiologic functions. So patient with primary lymphedema, I don't think they need to be too worried. Let's say if their arm has 98% function, so they're missing that 2%. Well, we may see people without primary lymphedema doing even worse just because they're not taking care of themselves. So, yeah.
So in the studies by the Chinese, did they look at all sorts of different kinds of dementia? You know, like not only just Alzheimer's, but frontotemporal dementia.
So the initial Chinese data, then I think as scientists uh, we can speak with factual information. Their early data are flawed in the sense that they comprise basically of these very dramatic before and after videos of how patients' behavior changed, and precise neurologic diagnoses were lacking. And so frequently, patients were lumped into the group as neurologically impaired without a precise diagnosis. But now, over 1,000 cases, this is what I heard from my colleagues in China. Over 1,000 cases have been done, and major medical establishments in China are now all involved. So I expect to start to see multidisciplinary care and start to see neurologists being involved. So I'm hoping to see higher quality data, especially the type of Alzheimer's disease. But just preliminarily, we don't expect this surgery to be able to treat all kinds of Alzheimer's and all kinds of Parkinson's, and potentially, actually, as we have discussed about this before, not just Alzheimer's and Parkinson's, but also a whole host of brain disorders, autism, ALS, Huntington's disease, and the list goes on. But we don't expect this procedure or lymphatic manipulation to be able to treat all of Alzheimer's or all of Parkinson's. We're still at a very early stage of just finding out that, whoa, these conditions, which have been traditionally considered untreatable, are actually potentially treatable. Then the next is we need to find out, how do we select patient? We all know doesn't matter what type of treatment, proper patient selection is extremely important. And then we also need to know, what are the contraindications and what patients should we not operate on? So these are all definitely questions that we know we have, and questions we're looking to answer.
That's fascinating. I imagine in the next 5 to 10 years, it's going to get more and more exciting and interesting, and more data is going to come out. Do you
What's
think?
interesting,
Go ahead.
I think things are going to come out very rapidly because this is now a global effort. It's not just us now. So for us, we're very happy to see this finally coming to fruition, because we started talking about it in 2016 and no one would accept, and everybody said, you're thinking about lymphatics too much. And but now everybody's working on it around the world.
That's
So
amazing.
with so many bright minds working on this, I think we're going to make significant progress very quickly.
I just want to thank you for being brave and continuing to present your data despite what other people said. And I think, that really deserves a round of applause, because without people like you, things just aren't going to move forward. So thank you for your bravery, and what a novel finding. Do you think that manual lymph drainage of the neck is helpful in Alzheimer's or dementia?
I think very likely, if surgical manipulation can produce an effect I think non-surgical manipulation should also, I think it's reasonable to speculate that there should also be an effect. And in fact, I have been in contact with several lymphedema therapists around the world who have reported such observations. And because of our role as researcher, we can't really promote and tell them, yes, go out and start to treat Alzheimer's. But I did encourage them, and I was trying to help them organize their observation. And I think definitely, if there are lymphedema therapists in the audience, I do recommend that lymphedema therapists, as you treat your patient, if you observe, if you heard your patient telling you, hey, my brain cleared up, observe them with a systematic method and record your findings in an organized fashion, reportable fashion. So your observation won't remain an anecdote. Your observation becomes evidence, and that other clinician, other researcher can build upon. This means that you need to bring your findings, your experience to meetings, present your experience, and you need to report them, write them up, turn them into publications. Start out with a case report. Once you have 10 patient, turn it into a case series. Once you have 30 patient, turn it into a larger case series, and turn it into a control study. Then it becomes evidence. So yes, I do believe that manual lymph drainage would have an effect.
And we talked a little bit earlier when we first got on about the pumping. So sequential pneumatic compression pumps or pneumatic compression pumps. And I know you've done some work on them. Can you give us a little bit of an idea of how you feel about pumps and whether they benefit lymphatic pumping?
So, Jimmy, I think pump, based on how we know lymphatic physiology and how we know external pressure definitely drive lymphatic flow, and how we know muscle contraction help pump the lymph. And this could be easily observed when we inject the ICG. There's not a whole lot of movement. The moment the patient start to move, that's the moment you start to see the lymph starts to flow rigorously. There's the intrinsic pumping by the lymph channel themselves, driven by the lymphangions. And then there's the external compression pumping, mostly driven by skeletal muscles. And if you think about the physiology, then pneumatic compression pump makes sense. What's lacking in the literature is really high quality evidence. When we look at when we perform a literature review, which was published, there are studies about pneumatic compression pump, but precisely most of the results are shown as volume reduction, which we know is highly manipulable and not quite reliable. They're shown as circumference measurement. They're shown as patient feeling better. We really need high quality, objective, hard evidence. For example, ICG lymphographic evidence that it's better, it's unequivocal, and it's not really influenced by patient's mood and your bedside manner, how you're approaching the patient. So those kinds of studies are lacking. We have previously conducted a study trying to take advantage of the fact that pneumatic compression pump can accelerate lymph flow. That is well proven, and we are taking advantage of that property of pneumatic compression. But the goal was to shorten our ICG lymphography to turn it from a 6-hour study down to a 10-minute study. But we had to drop the study because of limitation of needing to clean the pneumatic compression sleeve in between patients. We are currently enrolling patient on a study, pneumatic compression pump study, and we're doing fairly well on this study so far, and I expect to have a definitive answer, and then we will settle this question for good. that pneumatic compression pump, whether it is helpful or not. And I'm already speculating, and most likely that's going to turn out to be the case, that it is helpful. Our part two of the study, we would start to look into parameters: high pressure, low pressure, the sequential, the compression pattern, and the whole time, treatment exposure, treatment frequency, all those other treatment parameters. How to best, once we demonstrate that it is helpful or not helpful, assuming it is helpful, we need to know how to best use it.
What about the head? Should the head be pumped? I know it's kind of hard because you got a face and a nose and you got to breathe.
So I think at this point that if you're talking about head and neck lymphedema, I would say yes. If we can come up with a sleeve for the face, I think it would be helpful. It's difficult to compress the neck without creating some discomfort and potential airway issue. But just like how extremity, how torso respond to pneumatic compression, I think for the facial lymphedema, I can see pneumatic compression pump helping. And of course, the other question is for patient with brain lymphedema, can facial pneumatic pumping help? That we don't know at this time. We can certainly hypothesize, but your guess would be as good as mine at this point.
So if you have a patient who has early lymphedema and most of the swelling is in their face with only minor swelling in their arms and legs, what are your thoughts on that? That's a question from Shireen Winkler.
So that's an uncommon presentation, but we certainly have seen them. So you treat this patient no different from any other lymphedema patient. You start out with proper diagnosis. What we would do is facial swelling and extremity swelling could be easily assessed with ICG lymphography. If the patient also have torso swelling, if the patient also have abdominal ascites or visceral and intestinal lymphedema symptoms, then a imaging of the central lymphatics through intranodal injection in the groin would be warranted. We need to know what's going on in there. And once we know facial lymphatics, extremity lymphatics, and central lymphatics, where the problems are the problems diffusely located or their focal points of problems, then we can come up with a surgical strategy. So without knowing more, it's hard to say what we're going to be doing. For example, assuming if the patient has a focal problem at the thoracic duct, that actually would be a highly favorable situation. So assuming everything else is good, there is a stenotic segment at the thoracic duct where it goes back into the central vein. Then all you need to do is to take care of that stenotic segment. We probably don't even need to operate. Maybe the interventional radiologist can dilate that segment and done.
Nice.
Or if that segment is occluded, then we can perform a bypass in that region. Although that's actually uncommon. Most commonly, what we see is the problem is pervasive. It's all over. If that were the case, then we would intervene initially at the most severely affected segment. Most commonly, it's still the leg. And by the way, just because the patient is symptomatic in the face doesn't mean that you need to operate in the face. We've seen this numerous times. Surgery in the leg will help the face. So this is why I said in the beginning, and I can't emphasize that enough, this interconnectedness of the lymphatic system. It seems to behave as a single organ system. And this is also this underpins our finding of primary lymphedema being systemic, because if you think about it, primary lymphedema is underdevelopment of the lymphatic system. It's a congenital underdevelopment of the lymphatic system. It's not going to selectively underdevelop the lymphatic system of the leg. It just, the entire organ system is underdeveloped.
That makes sense. And that's fascinating to think about it as an entire organ. So there's another question here that may allow you to use the model that you showed us earlier. It's a question from Jean Richardson, and she says, can you talk about genital and abdominal lymphedema and treatment?
So again, this goes back to what I just said. Very commonly, well, we need to know where the problem is coming from. Central lymphedema, let's say issue with cisterna chyli, can actually reflux to abdominal wall, resulting in abdominal wall swelling. So sometimes people don't differentiate abdominal ascites, that's accumulation of fluid inside the abdomen, inside the abdominal cavity, versus actual abdominal wall swelling. And that is swelling they can see on their skin. So most commonly, when people talk about swelling, they're talking about swelling in the skin itself, actually in the interstitial space or the fatty layer. So assuming if the patient has acquired lymphedema, say for example, ovarian cancer, patient had pelvic lymph node ablation and radiation to the pelvis, then we know there is a focal injury in the pelvis. And what's downstream from the pelvis? Well, the pelvic lymph node drains both legs, and it drains the abdomen, and it drains the buttock and genitalia. So you would expect all these areas to have some symptoms. In the acute swelling, people will have swelling in the proximal aspect. That means genitalia, thigh, buttock, and lower abdomen. So assuming that's the case, then we know where the problem is. If we see the patient early and we catch the disease early, then the best intervention is what I just mentioned, because the immediate downstream lymph node from the pelvic lymph node would be the inguinal lymph node. And yes, this allows me the good use of my 3D model that our engineer just made for me for a case this week. So this is a hemipelvis. This is the pubic tubercle. So this is where the genitalia is. This is the iliac crest. So the leg is here. And the pink color you see is the femoral artery, and the big blue line you see there, that's the femoral vein. So these are the big artery and vein in our groin region. And this nodule right here, this blue nodule right here, that's a lymph node. That's an inguinal lymph node. And this is what we have already selected for this particular patient. That's the best lymph node in this patient's groin. So this week, we will be going in to perform LMVA, lymph node to vein connection. And that would be selecting one of these little lines that you see here. So these lines are in general about 1 to 1.5 millimeter vein. And we will be selecting one of these veins, and we will connect it to this lymph node right here. And so that would be the procedure, inguinal LMVA, lymph node to vein anastomosis. And this would be great in treating leg swelling, buttock swelling, genitalia swelling, and lower abdominal swelling. So lower abdomen drains to inguinal lymph nodes, and upper abdomen, if in normal lymphatic drainage pathways, they drain to the axillary lymph node. But it's important to note that, and this would be especially relevant for lymphedema therapists during MLD, to know that in lymphedema situation, the drainage pathways change, the patient collateralize, and they compensate. So sometimes in the lower abdomen, you will actually collateralize to the other side, or sometimes lower abdomen, because of the pathology in the lower extremity in the inguinal lymph node. Patient may actually drain towards the armpit. And this is why some of the therapists are talking about ICG-guided MLD, which is, of course, another topic, but it is very helpful using ICG mapping.
I wish all of our therapists could use that. You and I have talked about lymphedema previously, and could you tell me how pervasive lymphatic dysfunction is in patients with lymphedema?
So from what we see, all 100% of the lymphedema patient. So I understand the common teaching is that lymphedema develop at late phase of lymphedema. But from what we see, all lymphedema patients already have a coexisting lymphedema, which is also pervasive and systemic. Although what's interesting is that lymphedema seems to be an inhibitory factor on lymphedema. So even though we always see both conditions coexisting, in fact, because they happen 100% of the time, we use four-limb ICG to diagnose lymphedema. So we see a patient who look like lymphedema, and the patient reported all the classic symptoms of lymphedema. And our confirmatory study is a four-limb ICG showing four-limb lymphedema. And now we confirm the diagnosis. This is lymphedema. But what's interesting is that it's rare to see severe advanced lymphedema in lymphedema patient. That's very interesting. It's almost as if lymphedema has prevented lymphedema from getting worse. Even when they had it for a long time, it's uncommon. What I have seen is we know that being excessively overweight definitely can by itself injure the lymphatics. We have seen in lymphedema patients who were really, really heavy. Those were the exceptions when we see severe advanced lymphedema. Vast majority of the lymphedema patients have this very mild lymphedema, and actually many don't even have swelling, and that would be in agreement with the common classic teaching that lymphedema only develops in the late lymphedema stages. So I think probably in our experience in early lymphedema symptoms or lymphedema remains subclinical. They are asymptomatic, and unless we perform lymphatic imaging, otherwise we wouldn't see them.
How long does it take you to image the four limbs with ICG?
So we do both immediate post-injection scan, injection of the ICG, and then we do a vibration protocol to accelerate the lymph flow. And then we do a plateau phase scan. And so plateau phase means they don't change a whole lot once they plateau. And so if you leave it to patient themselves, it takes about 6 hours to plateau. Or to be more accurate, 83% of the patient plateau leave it to themselves in 6 hours. And then from 6 to 12 hours, the patterns would be unchanged. So we want to catch that plateau phase. And so with our current vibration protocol, we plateau at about 6 minutes. So following injection, we do a 3-minute post-injection scan. So for limb, that's 12 minutes. And then 3 minutes for injection, 15 minutes for the immediate scan. And then we vibrate for 6 minutes. It's a 2-minute on, 1 minute off, then 2 minutes. So altogether about 8 minutes with 6 minutes of total exposure, vibration exposure. And then we do our delay scan. So altogether, for limb would probably take us half an hour.
Half an hour. Yeah, that's very reasonable. And you're using vibration because vibration improves lymphatic flow?
Yes, vibration. Yeah, this is an entire topic. So there's a lot to vibration, and so that's another one of our studies. Vibration accelerate lymph flow. Again, similar to the pneumatic compression pump, we are looking into how to best use it. There's different types of vibration. There's the this, there's this, there's this, there's this. And so different types of vibration, there's the magnitude and also frequency of amplitude, frequency of vibration, and also the vibration exposure, the treatment exposure. Let's say if you're doing 6 minutes, is intermittent, on off better, or is 6 minute continuous better? There's a lot to it. And so there's some interesting study done by NASA, and people can look into it. So vibration is in general beneficial to health, and it's beneficial to so many of our bodily function and possibly also lymphatics. And I think anecdotally, we've all heard many patients reporting that they feel better when they use the not pneumatic. They feel better with pneumatic compression. They also feel better with the vibration.
Awesome. Going back to the pelvic area, Wouter van der Horst asks, do you feel that iliac vein compression syndrome or May-Turner syndrome might benefit from your surgical intervention versus placement of a stent only?
So the two conditions certainly can overlap, that we do see a lot, but also I think, and this is my recommendation to all the vascular doctors also, we need to be mindful that when we see a patient with lower extremity swelling, it could be a vein problem, it could be a lymphatic problem, it could be both. There certainly are a significant number of patients who were diagnosed with May-Thurner who turned out to not have May-Thurners. How do we know? Well, we know when they went to the operating room suite and the vascular doctors found out that even their largest stents were smaller than the patient's vein. Then you know the patient couldn't possibly have May-Thurners. So just because we saw that the iliac vein is being compressed doesn't mean that it is significant. So that's really a vascular debate, and I think it's best to leave it to the vascular specialist. But given the fact that every year we see a significant number of patients who were stented and have no improvement in their swelling, that was when their vascular specialist said, you probably don't have May-Thurner's. That May-Thurner syndrome was an incidental finding. So we certainly need to be cognizant that with modern technology, we are catching many things that probably don't need to be intervened upon. Um, so now with that said, untreated, not just May-Thurner's, but also venous insufficiency, particularly deep venous insufficiency, can result in lymphedema by overloading the lymphatic system, as we all know, febrile lymphedema. So venous insufficiency need to be treated. Not so much the superficial venous insufficiency, not the vein ablation, not the sclerotherapy, stap avulsion. The superficial venous insufficiency isn't as worrisome. It's really the deep venous insufficiency that's definitely a factor that we always need to evaluate for in performing lymphatic surgery, because that is an independent cause of leg swelling.
So if you, just to kind of wrap, gosh, I need another hour with you, but if it's not May-Turner, and let's say it's not deep venous insufficiency or superficial, why does that left leg swell more, especially like, for example, in primary lymphedema? What is it about the left side of the body? Do you have any idea?
That we don't know.
Okay. Yeah, I wasn't sure. So I want to come back to the dementia Alzheimer's studies. There's a lot of people, obviously, who are very interested in this. They're interested in clinical trials and whether you're performing the surgery now.
So what we are currently performing is we are treating patients with lymphedema. So we certainly can treat patients with facial lymphedema, head and neck lymphedema, who happen to have Alzheimer's. But as of today, we cannot treat patients. I can't tell you to come in and we'll take care of your Alzheimer's disease. And as I said, we are 1 to 2 years away from that. And actually, the bulk of the cases as of today have been performed in China. And the very first case outside of China was performed in Taiwan. And interestingly, both the surgeon and the patient's son are my friends. And the patient's son is a well-known plastic surgeon in Taiwan. And the surgeon who performed the surgery is a well-known plastic surgeon in Taiwan as well. So that case was just performed in October with phenomenal result. The second case outside of China was just performed 2 months ago in March in South Korea by another well-known plastic surgeon at the Sun Medical Center. So rest assured that more and more data will come out. And we here at Cleveland Clinic, we're working on our IRB. So we are extra cautious, obviously, given the gravity, how important this study is. We want to take all the precautions and we want to do good science. And this is a multidisciplinary trial involving our neurologist or neurosurgeon. And as you can imagine, at a big institution, when there are many doctors involved, things don't go fast. And just getting even an online meeting, a virtual meeting of everybody involved, we're scheduling a few months out. Everybody is so busy, but we're going to make that happen. We realize how important this is, and we realize that many are awaiting our data, despite all these encouraging news coming in from around the world.
So if a patient would like to come see you from Canada, the US, Mexico, wherever, how do they get in to see you especially if they have lymphedema?
So very easy, call Cleveland Clinic main campus, ask for Dr. Chen's lymphedema surgery service. And the bulk of our patients are from out of state, from abroad. My office is streamlined to take care of patients from far away. So
Great. Thank you so much. And let's say a patient has a very underdeveloped lymphatic system, could you get a donor lymph node and bring that into the lymphatic system?
well, fortunately, no. The short answer is no. And fortunately, we haven't really seen the need of doing that. And but a very important concept is that the lymph nodes don't really drain. It's not the lymph nodes that drain. It's the lymph vessels that drain. And this finding was an analogy that I frequently use for my patient is it's the freeway that moves the traffic. It's not the toll booth. Think of lymph nodes as toll booth. So if anything, without a toll booth, the traffic would move even better. So the lymph node sample the lymph. It's not really propelling the lymph. This is what caused us to initially move away from lymph node transplant. There was a time that my go-to procedure was lymph node transplant. That was a long time ago. And the finding that it is the lymph vessels that matter prompted us to develop the lymph vessel transfer. And that was my go-to procedure for a while until we finally refined the LVA enough And we then found out that all patients with fluid predominant disease were treatable with LVA, and we no longer need to transfer anything, which is good because any of the transfer procedure, whether we are transferring lymph node or lymph vessels, we would be damaging another part of the patient's body. And we can say it's only a minor damage, but it's still a damage, still an injury that we're creating.
And so I heard a collective groan in the audience when I arrived back on the screen, because that means our hour has come to a close. But I think Julia Burdine in the audience speaks for everyone. She says, I feel like we just scratched the surface. So glad these advancements are on the way, and so grateful for everyone's work on these issues. Dr. Chen, can we twist your arm and have you back again soon?
Sure.
Wonderful. Okay, we got that on the recording. Wonderful. And I want to thank all of you who have logged on for this live presentation. Your questions, your chat, it helped to make the hour just go by like this. We really did just scratch the surface. Our president, Eric Ansard, is also in the audience, and he's also clamoring for more Dr. Chen. Any closing words, Dr. Chen, and then Dr. Herbst to wrap it up? What would you say to our audience of both patients and clinicians, Dr. Chen?
Um, so I think many patients who are in the audience probably are here because they're interested in the topic of lymphedema. And I think looking back in the past 20 years, when I've been involved with the treatment of lymphedema, we can see vast and rapid, incredible advancements. And as of today, I think definitely it is fair to say that patients, lymphedema patients, can expect that they will get a good result. And that's what we are seeing, consistently favorable results and consistently, vast majority of the time, really happy patients. So I think as of today, we can say that lymphedema is not something that you need to feel depressed about. I have so many patients who said they feel that this is worse than their cancer. This is making their life miserable. I think there's no need to feel that way. What is true is that lymphedema expertise is exclusive, and it is exclusive for multiple reasons. And for the most part, it's system problem, and that we're working on improving. So I think probably the most important message that I want to bring to people is that lymphedema is not just treatable, but very treatable. And we're not ready to say that we have beat lymphedema already, but I would say we're not far. We're already looking at lymphedema's cousin, the brain lymphedema, or extremity lymphedema's cousin, the brain lymphedema. We're already on to the next challenge. And by the way, these are all related. It is from successfully treating extremity lymphedema, truncal lymphedema, that have led us to the brain lymphedema. And the pursuit and investigation on brain lymphedema will also help us be able to treat extremity, the rest of the other types of lymphedema, even better. So we're continuing our investigations. We're continuing our pursuit for superior treatment. And so things are happening more and more rapid. I think we're advancing at an exponential rate. So I think I want to leave people with optimism. And yeah, lymphedema is very treatable.
Wonderful. And Dr. Herbst to close us out.
All I can say is it's priceless to have hope, and the fact that you've, I think, really driven home the point that the lymphatic system is an organ, that everything is interconnected, and that it can be treated in everybody, in almost everybody. Let's say 99.99% is just so hopeful, and I just want to thank you for everything you've done and in driving this field forward.
Dr.
Thank you.
Herbst,
Thank you,
Dr.
Karen.
Chen, amazing night. Applause is happening all throughout chat. We want to encourage you every month. Dr. Herbst does a one-on-one and sometimes with more experts about a topic that is on the cutting edge of research that will be meaningful to both clinicians and patients especially. If you've never attended one of our lipedema or lymphedema patient roundtables, we've built a community here at Lympha Press to support you. You are not alone because aside from the physical toll, there are emotional burdens, and we like to help you meet those with other like-minded people who are managing their conditions successfully. So please do sign up. Thank you, everyone. We went over, but we had to. It was Dr. Chen. Have a great night, everyone. We'll see you again next month. Thanks so much. See ya.
Bye-bye.
Bye.